Now we are starting problem-based learning discussion. The chairpersons for the first sessions are Dr. ShalooIpe, Professor, MOSC Medical College, Kolenchery, and Dr. Ansar, Associate Professor, Government Medical College, Trivandrum. We invite you this session. The topic of discussion is anesthesia for elderly patient with super obesity. The speaker is Dr. Aparna Sinha, Consultant, Max Super Speciality Hospital, Saket. Over to you, madam.
So, welcome everybody and greetings of the season. I'm Dr. Aparna from Max Super Speciality Hospital, and I bring greetings from Max Institute of Laparoscopy, Endoscopy, Bariatric and Robotic Surgery. So at the outset, I would like to thank Dr. Radhakrishnan and Dr. Sajeesh and all other organizers for having me here on this very interesting and very pertinent session on anesthesia for elderly obesity. I have no disclosures to make and no conflicts of interest whatsoever. The lecture is based on my current evidence and my personal experience. So what are we going to learn today? What are the anesthetic challenges in elderly patients with morbid obesity? How do we evaluate them? Which patients are at risk? Which is the best form of anesthesia for them? And what is the journey of an elderly obese after surgery? So a quick look at what is happening at the anesthesia front. So when we look at the outcomes after anesthesia, we will see that the outcomes have been only improving with every passing year. And currently, the safety outcomes, the morbidity and mortality following anesthesia is minimal. And it is more than 95% survival after anesthesia. And they are very negligible causes of morbidity after an elective surgery. So, but what does the evidence show? The evidence shows that when we analyze the outcomes after anesthesia, we see that, the adverse events that happen following anesthesia are mostly because of medication errors or improper monitoring. And when we have a closer look, we find that these adverse outcomes are mostly associated in obese patients and in obese patients who are suffering from sleep apnea. And when we analyze the pattern of outcomes in an obese patient, we further find that the hazard ratio following anesthesia increases when the BMI increases more than 35. And higher the BMI, higher is the hazard ratio, which means possibility of having morbidity and mortality following anesthesia or surgery, even if it is elective surgery, is higher with higher BMI. And this further magnifies in the elderly patients. So the prevalence of obesity among older adults in United States, unfortunately, we do not have, parallel data in our country. We find that, it is maximum between 65 to 74 years of age. After 74 years of age, the prevalence of elderly with obesity goes down, and so is the case when we compare individuals lesser than 40 BMI. So the most prone individuals are individuals who have morbid obesity and have an age group between 65 to 74 years. And the prevalence of people in this bracket is only rising, which means that more and more chances that we encounter them during our practice. So when it comes to evaluating the risk associated with an elderly obese, we must first of all definitely try to find out how long the patient in her lifetime has been obese. So if a patient has been obese right from the childhood, and continues to be obese or having a rising BMI throughout their life, their chances of succumbing to a cardiovascular event following an elective planned procedure is much higher. Now, this can be described as pound years. So more the pound years, more are the chances of encountering adverse event following anesthesia. So increased mortality due to cardiovascular diseases, as we can understand, there is so much evidence in different journals and world over, in different ethnic groups, in all types of studies that have been done. We only find that higher the BMI and more the age, higher is the. So further, when we look at outcomes, now this is data from National Surgical Quality Improvement Program, which has, really analyzed a very large database of more than 11,000 patients from different healthcare facilities across the world. And what did they find? They found that more adverse outcomes are associated if a patient is having a dependent physical status, have had a recent MI or angina, is suffering from a bleeding disorder, is a hypertensive, or is having extremes of BMI. So definitely right now we are discussing super obesity. So we are discussing patients who have more than 60 BMI. So we can understand that evaluating the functional status of the patient and improving that becomes extremely vital to have a good anesthetic outcome, be the patient for an elective surgery or an emergency surgery. So we must, as far as possible, try to evaluate and improve the functional status of the patient. So the aim of pre-op assessment of this patient should be increasing the functional reserve, doing the routine or the standard anesthesia assessment of the oxygen reserves, assessing the cardiopulmonary reserve to gauge the difficulty of airway, to look for all possible comorbidities and find out any concurrent medications. And wherever possible, there should be optimization of the comorbidities. And we should identify patients which can be called for a periodic assessment. So what are the challenges here? The challenges are to evaluate and do the risk assessment, which can be age-related and obesity-related. Then we need to prepare the patient and decide the anesthetic technique. So prehabilitation is what we need to do, and this is possible definitely only in an elective surgery. So prehabilitation involves preparing a patient for stress of major surgery by initiating the recovery process even before the commencement of surgery, and hence enhancing the preoperative functional capacity. So how do we do that? Now, invariably, these patients would be suffering from severe osteoarthritis, would be having some spine issues, having PIVD at multiple levels, and because of long-standing morbid obesity with abdominal adiposity, their spine structure is constantly under stress and undergoes, deformity in form of shape and in form of prolapsed intervertebral discs with compression of nerves at multiple levels. So that is a constant problem, and that is one of the reasons that brings the patient to the hospital for an elective procedure. Then they might be suffering from cardiopulmonary compromise owing to the large size, having massive pedal edema, which is dependent pedal edema, and because of compression of the large veins, because of the abdominal weight per se. And most importantly, so sarcopenia. Now the elderly obese would be suffering from sarcopenia. And if you see the younger obese, they might be having good muscle mass because their body is lifting a constantly heavy weight throughout. However, with onset of age, the sarcopenia ensues. So we need to identify the individuals and we need to motivate them. So it is not that we expect them to go to the gym, but whatever is possible to the best of their abilities in the environment that they are staying, they need to indulge into some sort of a physical activity, which may be lifting weight, maybe in the form of water bottles that are, available at home, or going for gentle walks with the Okay, so we need to increase and we need to involve them with their family members, and we definitely need to educate the family members as well. So evaluating this big and the breathless patient, we know that, they are dyspneic even at rest. So it is not necessary that they are having a cardiac compromise. All of them are suffering from restrictive lung disease because of physical immobility, which is long-standing. There is physical deconditioning, and the heart and the lungs are constantly under pressure. So that is known as the anatomical remodeling. So they present like a failure patient. So the causes of dyspnea are multifactorial. So, we need to identify the comorbidities of this patient, and all these things we can take up in the discussion section. And we are aware that, their pulmonary dysfunction could be because of not just low lung volumes, a higher airway resistance, and leading to impaired gas exchange, then presence of obstructive sleep apnea leading to constant pulmonary hypoxemia ultimately leads to pulmonary hypertension and biventricular sort of failure. So it is not even possible to do a 6-minute walk test. So because of presence of massive pulmonary edema, there is friction between the legs, there is severe osteoarthritis, deformity of the legs, varicosity, prolapsed PIVD at multiple levels, So there are so many causes because of which they may not be able to move. So that poses a challenge in evaluation of the patient. So we become more and more dependent on our clinical judgment. So it is not even possible to assess their signs of failure because there is so much of fat around their neck. You cannot see the JVP. You may not be able to appreciate the breath sounds. So a lot depends upon our clinical judgment. And of course, this can be corroborated with some basic investigations, because even dobutamine stress echo or treadmill is definitely not possible in these patients. So we need to have a very high index of suspicion. So we need to find out what is their frailty index, how much work they can do. Can they go to the washroom? Can they even button up their shirts? So more and more dependent that they might be, higher is the frailty index. So any score that is more than 4, we can find these scores readily available now. There are apps, they are available from where, we can feed in data and readily calculate the frailty index so that we can identify which of our patients is likely to have a poor outcome. Then identifying patients and the severity of sleep apnea. We all are now familiar with stop band scoring score. So that needs to be fed into our pre-anesthesia evaluation chart for all the patients. And any patient who has a score of more than 3 needs to be marked as a moderate to severe sleep apnea. We need to choose the right equipment for monitoring the basic vitals of the patient. Then simple ECG, signs of right ventricular hypertrophy can be suggestive of pulmonary hypertension. Left ventricular branch block can be suggestive of coronary artery disease. We can find cardiomegaly. We can see pulmonary vascularity and get an idea of whether there are chances of pulmonary hypertension. Then echo, if at all it is possible, we look into the right ventricular systolic pressure and gauge the degree of pulmonary hypertension, which is suggestive of pulmonary hypoxemia. Then the breath holding time needs to be documented for all the patients. Then we begin our optimization right from the time we come in contact with the patient. Patient's position has a vital role to play. Patient should be encouraged to be nursed in a head-up position because that is how the airways will open up. So even if we are applying non-invasive ventilation to the patient, unless the airway is opening up, it will not be very effective. So even pre-induction CPAP has a large role to play in increasing the safe apnea time. Then look at the factors which predispose the patient to post-operative complications like venous thromboembolism. So if the patient, whether or not patient is having pedal edema, we need to give thromboprophylaxis. So if in addition to pedal edema, patient is having varicosity, polycythemia, thrombocytosis, history of previously having taken some hormonal supplements, or patient is a smoker, definitely this patient is very likely to develop thrombosis and embolism in the post-op. So thromboprophylaxis and early ambulation or some sort of a deep sequential compression device needs to be in place. So typically the pre-op instructions will not include any sedative. So the entire team needs to be alerted about how to manage these patients, especially in the post-operative period. The antihypertensives, the thyroid medications, the psychiatric medications need to be continued into the perioperative period, because invariably these patients are having low self-esteem and are on some sort of a psychotropic medication. So we need to spend some time alone with the patient so that we can take out this history from the patients, carefully assess the airway, find out the venous access, position the patient properly, decide what monitors to be put. We can bring up these discussions in the discussion period. Both inhalational anesthetics, which could be sevoflurane or desflurane, or even total intravenous anesthesia, is very good in having a safe outcome for the patient. Then, as far as possible, use a bispectral index guided anesthetic management. Be careful about fluid management, because fluid administration is definitely not as per the total body weight. We need to do a goal-directed fluid therapy and use a multimodal analgesia for pain management. Identify the patients in whom the landmarks are not visible, because these are the patients where we will be having difficulty in external manipulation, difficulty in even laryngoscopy or even applying cricoid pressure. So we need to find out which patients we need to do awake fiber optic assisted intubation, and in which patients we can manage with the help of video laryngoscopes. Then on table preparation of a ramp and the right ramp, and training the technicians around us to make the proper arrangements for making the ramp, so that we do not waste time in the operation theaters. Then apneic oxygenation should be continued into the perioperative period. This has been largely emphasized in the current upcoming ASA 2022 airway guidelines. Then CPAP can be continued right into the pre-oxygenation and even into the post-operative period. Some centers are using transnasal humidified rapid insufflation ventilatory exchange. We do not have it in our center. Buccal oxygenation has been tried by several practitioners. Now, arm-brain circulation. Now, arm-brain circulation is very slow in the elderly. Now, that is how they are different from the younger elderly. So small incremental doses of minimal amount of anesthetic agents should be used. So intraoperative ventilatory strategy, try to use positive peroperative protective ventilation wherever possible, right from the preoperative to the postoperative period. Intraoperatively, lung protective ventilation in the form of low tidal volume, positive end expiratory pressure, and recruitment maneuver is extremely important. The patients with obstructive sleep apnea definitely have a poorer outcome in the post-operative period. So there will be patients in whom regional anesthesia might be a better option. So regional anesthesia also does not come without challenges. So if our center is having a facility of ultrasound, then it will help us in identifying the correct plane and in identifying if we are using a centrineuraxial or a interfacial block. Then identifying the structures becomes much simpler and the outcome becomes much better. So we definitely need to keep practicing and having individuals who are trained in performing the regional techniques. So it is not that the regional techniques are without any problem. Even performance, having the right size of the needle and to figure out whether our block is successful or not is very vital. And so perioperative risk reduction strategy, we have to limit the opioid dose and use opioid-free or opioid-restricted analgesia, positive pressure, and perform recruitment maneuvers wherever possible. Use multimodal analgesia, monitor post-operative end-tidal CO2. So do not hyperoxygenate. Look at the patients who are retaining CO2. So just application of a non-invasive ventilatory device might be sufficient for them. So continue NIV till the return to normal sleep patterns. Maintain a high degree of suspicion for OSA, educate and interact with the surgeon, use clinical scoring system, preoperatively optimize and educate the patient family. So now let us have a discussion and see further what we can do about these patients.
A warm good morning to all. I take this opportunity to thank Dr. Radhakrishnan, Dr. Sajeesh, and the rest of the organizing team for giving Dr. Aparna, Dr. Ansar, and me a chance to be here. Morbid obesity is on the increase, and more so in the increase is more in the developing countries compared to the developed. And the anesthetic management is evolving and controversies do exist. And even though you are not a bariatric surgeon, a bariatric anesthetist, you are going to encounter these patients more often now. Now, the Dr. Aparna has given us a kick start by her robust and clear presentation. Now we move on to the case scenario that is given to us. Just projecting the slide on the screen. This is the case scenario which has been given to us. This is a 67-year-old ASA 3 patient, 185 kilos, BMI 65.5, hypertension and diabetes lasting for 25 years, and Multicenter 2 classification. Lower back has difficult landmarks, and she's posted, obstructive sleep apnea symptoms are present. She is posted for an excision swelling of left calf mass, which has been there for the past 1 year. So in other words, she is a class 3 obese patient with with comorbidities like long-standing hypertension, diabetes mellitus, and sleep apnea symptoms. And it is an elective surgery. She's posted for excision or swelling on the left calf. Dr. Aparna had beautifully coordinated the preoperative assessment. We will start with the time limitations we have. Dr. Aparna, can you summarize for us how you will pre-evaluate this particular patient we have at hand?
Yeah, sure, Dr. Shaloo. So as I said, now this is a lady whose age is 67. So she is in a geriatric age group. And although if this lady was in Japan, it would not have been taken as a geriatric age group. There, the geriatric age group starts after 75. So for our population, definitely 67 will come in a geriatric population, and she has a BMI of 65.5. Now, if I carefully look into the presentation, they are saying that this patient underwent 2 cesarean sections, which were uneventful and were possibly done under a regional anesthesia, probably a subarachnoid block. Now, what I want to point out here is now, she must have undergone cesarean, maybe she was in her 30s. Right now it is 67. Let us take it as 70. So good 30-35 years have passed. So we are not sure how obese she was then. So just because, we have a history that she had an uneventful anesthesia cannot be extended to the present time because, good 3 decades have passed. A lot of changes have happened, not just in her spine, but maybe she has gained more weight. So that history is not very clear. Now, in this particular patient, we must find out what are the comorbidities. It has already been told that she is hypertensive and diabetic. Now, in both hypertension, diabetes, and in sleep apnea, there are very high chances of having a biventricular failure, which means that the right-sided as well as the left side of our heart is constantly under stress. So she definitely we need to find out what her cardiac status is. Now, though there's a swelling, it doesn't seem like a dire emergency. So we do have time to evaluate and, if possible, prepare the patient. So if I look at her angles, I'm not very sure whether there is pitting edema. Quite possible there is. And in presence of OSA, definitely there is some element of right-sided failure and long-standing hypertension and OSA. So we must find out, what is the status of her heart.
Now, if I cannot take this patient for a treadmill, for two reasons. One, she may not be able to walk because of presence of severe osteoarthritis and the swelling in her left knee, but also because we have imaging challenges. The treadmills in most of the places do not allow a weight of more than 150 kg. So if I have a patient who's more than 150 kg, definitely treadmill is out. So what we are left with is a dobutamine stress echo. Now, dobutamine stress echo also, because of the presence of, heavy chest, the echo windows may not be very clear. So what I'm trying to emphasize here, that our clinical judgment is very important. So ECG itself, X-ray itself will give us a large message about what is the state. So if I do not find cardiomegaly, if I would invariably find that the lung fields are very restricted, so I may not be seeing more than, 4 or 5 intercostal spaces, which means there is severe restrictive lung disease. In the ECG, if I am seeing right bundle branch block or, P pulmonale or a picture which is suggestive of a right-sided failure, I know that her right side is under stress. So if we are lucky and my center is having a transesophageal echo, then that may give us a better idea. But mostly a transthoracic echo becomes a challenge in absence of experts. So if I have a team where, the expertise is of the level that even in presence of so much fat in front of her chest, I'm able to find out what the heart is like, what the 2D echo is like. Otherwise, I would probably depend upon a transesophageal echo, and I will correlate the findings with ECG and X-ray. I would do, a breath holding time, for example, to find out what are her respiratory reserves. And if a surgery is such that it allows me some time, if, for example, it's a swelling, not an abscess, then maybe I can wait for some time, put the patient on some diuretics. Now, there are centers where we have machines for body composition analysis, like we have in our center, like we have in the gyms. So patient stands on that. It tells us how much extracellular water is there. Now, in this sort of a patient, if I put her on some diuretic for a couple of days, I put her on breathing exercises in form of deep breathing exercises in form of incentive spirometry, definitely her breathing reserves will improve. If I can get an ABG, I can find out if there are signs of CO2 retention, if she's looking more like obesity hypoventilation syndrome, or she is a much better sleep disordered breathing in the sense that the OHS element is not low. Then I am better off, I put the patient on a non-invasive ventilation for some time and reassess her after a week. Now, when I reassess her, I see what are the changes in her pH. Is her CO2 showing an improving trend? Is her PO2 showing an improving trend, which will also mean that patient is understanding the nature of an IV that I'm using. Sometimes patients don't understand. They put the mask and they have not been explained well enough that they have to coordinate with the, the breath of air that is coming, and that is how they are going to allow the CPAP or the BiPAP to take effect. So once that happens, we can figure out from the SD cards that are there in the BiPAP machines, and that gives us a lot of information. So if my patient is compliant, then definitely depending on the surgery, I can choose a GA or a regional also in presence of experts. Now in this patient, if I have longer needles, if I have expertise, I can go for subarachnoid block or a combined spinal epidural as well. Although this doesn't seem like a very extensive procedure, so a single short spinal will also do. Now there are places where they do femoral block and adductor canal block that can be combined with some degree of conscious sedation. And that's how, and we may not always go for completely opioid-free analgesia, but opioid-restricted analgesia, which means a small dose, maybe intraoperatively in case I'm giving GA to my patient, or I can just use a small amount of meditomidine infusion.
Because short of time, can we move on to the, so you have optimized, investigated thoroughly, and you have staffed the patient adequately, counseled, VT prophylaxis started, starvation guidelines achieved. Now we have got the patient in theater. What are the possibilities of anesthesia that you would think of?
Yeah, so I just mentioned about both GA and regional in this sort of a optimized patient, but most importantly than the anesthetic technique will be the position of the patient. So irrespective of whether I'm choosing regional or GA, a ramp should be in place, because even if I'm using a regional block, patient has to remain comfortable and her breathing capacity has to be under fully optimal conditions. So I will not remove the ramp. So, you know, there are troop pillows available, there are ready-made ramps available. If they're not available, we must learn how to use the readily available pillows and sheets to make a ramp, you know. So patient's head end should be elevated.
Again, I'm interrupting for lack of time. On broad basis, what are your anesthetic choices? The doctor.
Yeah, so I have actually, Dr. Shaloo just mentioned about both GA and regional, you know. So for this sort of a patient, even if I'm fully, my patient is optimized, I will love to give general anesthesia also, because, you know, under general anesthesia, the airway is fully under control. And if the position of the patient is expected to be supine at the time of surgery, then even a supraglottic device can be put, you know, a third generation supraglottic device in form of a ProSeal, which has a drain tube and which allows me to give positive end expiratory pressure. And whether I'm using GA or regional, for making the patient quiet, I can use dexmedetomidine, which can give act as an adjuvant as well as give some sedation to the patient without compromising the respiration of the patient.
Madam, if you are using a regional technique in a ramp position, will you modify the dose if it is a subarachnoid block?
See, head-up position will be fine. I mean, patient can be given the block in sitting position, and once and the patient can be put on the ramp, so the lower part of the body definitely will get the benefit. So having a little head-up will not harm the block in any way. That is what I think, you know. So the problem in GA would happen if it is the upper part of the body, where, you know, I may need to reduce the ramp a little. I think we can have a little head-up position even with the spinal. That is possible, yeah.
Dr. Ansar, like we all vary in our techniques, what would be the technique you would want to use? Because we all vary, but finally, what is best in your hand works?
Just like Aparna madam told, it depends on the position of the patient, their own comfort. I give more weightage for the position of for the comfort of the patient, preferably. Then we can opt for a regional or a general. And of course, we will be more confident on general anesthesia once the patient's airway is in our hand. So preferably I will go for a regional, but of course we should be ready with general also.
Now, if you would ask me, my surgeon would want the patient, I'm sure would want the patient prone. In that case, my choice would be general anesthesia combined with regional block. For example, a popliteal, continuous popliteal block with a catheter in for analgesia, which I can use post-operatively also. I would, if they would allow me to use a lateral position, probably I'll think of a single shot epidural or single shot subarachnoid block. But I wouldn't want to put a catheter in, epidural catheter in, for the reason that I want to start, they were preoperatively 12 hours prior, they were on VT prophylaxis BD dose, and post-operatively, if the surgeon is happy, I would want to start it as soon as it is possible. So for my the choice will be for a general anesthetic with an catheter, for popliteal catheter in place for intra-op and post-operative analgesia. Like we all vary in our techniques, and what is best in your hand works. And for GA, I would personally have an endotracheal tube in considering her huge size and comorbidities and obstructive sleep apnea. And Dr. Aparna, how would you want to get the tubing? How do you like the endotracheal intubation to be?
I didn't really get the question. How do I like the endotracheal?
How do you want to propose to do the endotracheal intubation?
Yeah, I mean, if I have to put my patient, yeah, because the neck seems to be, not too huge. The Malampati is fine. So definitely, I don't think anticipate problem in intubation. So most of the times, these patients who are sleep apneic have problem in difficult mask ventilation. So if I'm having difficulty in mask ventilation at the time of ventilation, one can also use a supraglottic device as a conduit. And we mask ventilate using the supraglottic device. We remove it. We insert either a Macintosh or a video laryngoscope that is available and go for intubation. So I don't sort of anticipate, a problem in laryngoscopy and intubation, considering the fact that Malampati was written as 2. So looks like the tongue size is also not huge. So upper part of the airway seems to be fine. Neck doesn't seem to be too swollen and the landmarks seem to be well defined. So I would not anticipate problem. Nevertheless, my difficult airway cart would be ready. My supraglottic devices would be ready. Video laryngoscope, if possible, should be made available. And for giving this thing pre-oxygenating, at the time of pre-oxygenation, we should ensure that, some sort of a positive airway pressure is going. So there is a lot of emphasis now on perioperative positive airway pressure, which starts from the pre-op and continues into the post-op. So in the pre-op, it starts in the form of either NIV, if it is much in advance, or on table, we can, use CPAP at the time of pre-oxygenation, then PEEP at the time of mask ventilation, and throughout the intra-op period, recruitment maneuvers wherever possible, and PEEP, and a higher PEEP if possible. So that is the way to go for protective ventilation and using a tidal volume.
I am interrupting. Dr. Ansar, your views on how you would want the endotracheal intubation?
Definitely, I follow with Aparna madam. We prefer by navigation under vision also. I'm again interrupting because of the lack of time. Madam, what will your planning on preventing rhabdomyolysis? Will you use elastomeric stockings, or whether you monitor with the serum creatinine counts?
Definitely. So intraoperatively also, wherever possible, sequential compression devices and TED stockings have been suggested. And in our center, they are being regularly used. And in this patient, because of the leg swelling, I'm not sure if it is possible to put the TED stocking on the left-hand side. But definitely in a patient where it is possible, we should be putting, and intraoperatively sequential compression devices. Now, rhabdomyolysis is, we suspect more when the duration of surgery is more than 4 hours, if in a male patient, or if it was a patient was smoker, or it was a laparoscopy of a longer duration. So in those sort of patients, we definitely expect to find. So we are not doing.
How will you monitor? Will you monitor with the serum creatinine count, or
if I'm suspecting? So not in every patient we are doing serum creatinine. So urine output, definitely we want to keep a check. Urine color, we want to keep a check. So if it is a straightforward surgery, which is less than 3 hours, mostly we do not monitor using serum creatinine. We are not doing.
One more question. Suppose we are planning for controlling under general anesthesia. Suppose if the patient is with gastric balloon already in place, what will be your management? Will you deflate the balloon preoperatively, or will you keep the balloon there and continue with the general anesthesia?
No, we deflate it if a balloon is there and the surgery. So it depends whether the surgery is related to GI or, it is a peripheral surgery. So mostly we let it remain in situ. So we do not deflate it. And if it is an abdominal surgery and deflation is required.
About the gastric aspiration with the balloon itself. That's my concern.
So you're right, absolutely. So although the chances of finding patients with gastric balloon is almost zero now, because gastric balloon is like almost obsolete. So ballooning and banding, but yes, if it is a patient with balloon, we would sort of take that patient as a full stomach patient and be very cautious and maybe use rapid sequence intubation for such a patient. But having said that, RSI is also not like a very foolproof or a straightforward thing, especially if the landmarks are not visible. So having a patient in a head-up position and doing a gentle emptying of the stomach prior to beginning the process of anesthesia might be a better option. Because just because I may suggest that I will do RSI, I may not be able to even see the landmarks. So, we have to sort of evaluate each patient as it comes.
What about the muscle, your muscle relaxant of choice for intubation? Is it succinylcholine or rocuronium?
No, it is the long acting only. So atracurium or cisatracurium. We are not using spoline routinely. So I think probably
you have Sugamadex available always.
Only then a rocuronium. Only then a rocuronium. Otherwise, either a long acting, or if in specific cases, if patient is giving history of gastroesophageal reflux, or if it's a emergency surgery where I'm not sure about the fasting status of the patient, only then I would go for a short acting. Otherwise, long acting, we have not had any problem so far. And if my team is familiar with point of care ultrasound, then even stomach contents can be seen using the ultrasound. So youngsters are getting more and more energetic and familiar with the application of an ultrasound probe for finding out the stomach content.
Any advantage on long acting compared to succinylcholine? Because succinylcholine, we are telling that it will be weaned off easily, but it will take at least 5 minutes to wean. But if there is a mishap with long acting, we almost always have the Sugamadex in hand. We can reverse it immediately, right? Am I right? Okay.
I think the current airway guidelines are rather enforcing that we should relax in case of any problem and, sort of try to have a better access into ventilation and airway. So I would beg to differ on that. And I would stick to a long acting rather than short acting. But if there is some obvious indication of, if I, for example, find that, mask ventilation is might be impossible, or, if the patient is having a small mouth opening.
My question was, succinylcholine will take its own way to metabolize, but we can always reverse rocuronium. So I think the safety profile is more with the rocuronium, right? Am I right?
Yeah, that is true. If I am comparing rocuronium with succinylcholine, yes.
But
yes, between the two, maybe
Sugamadex available?
No, not with us. I don't think so. We don't have. I don't think it is available, and if at all in centers, it is, I think, extremely expensive. So it is not feasible in our kind of patients.
So because you are short of time, one last question about because this is a high risk extubation, how do you plan your extubation, and post-operatively, what are the things you take care of?
Yeah, so one, I will answer this question, and I think one of the audience wants to know about venous thromboembolism. So I will request organizers to give me a few minutes on that as well. So about extubation, wherever possible, I would love to use a bispectral index guided anesthesia management, and try to have an awake patient in the post-op, so practicing enhanced recovery after surgery. So using shorter acting and, rapid emergence techniques is the way to go. And once the patient is fully awake, or at least having swallowing reflex, once the swallowing reflex is there, we can definitely remove the airway support. And the recovery should be closer to the operation theater. The recovery area should be closer to the operation theater. If it is at a little distance, then en route we should have oxygen on flow, so that in the initial period when the patient is still a little sedated, even after extubation, oxygen should be flowing. So once the patient is settled in the recovery, then we can, sort of start targeting the pre-op oxygen SpO2 levels. Till then, we should be giving high flows of oxygen. And for extubation, there are different techniques like Bailey's maneuver, or people are using, stellate-guided extubation, leaving the catheter inside and extubating on the catheter, so that just in case re-intubation might be required. But in surgeries that are not related to the airway, mostly if my patient was awake at the time of extubation, and if I ensure that patient is maintained on a ramp at the time of extubation, and I should be having sufficient help. So if my intubation was difficult, in the form of difficult laryngoscopy or difficult mask ventilation, I should have additional help at the time of emergence as well. So mostly it has been seen that, at the time of induction, the number of personnel is X. So at the time of emergence, the number of personnel available is X by 2 or X by 3. So that should not happen. We should have expert help available even at the time of emergence. And I think ramp should be continued till the end of surgery. So if for some reason intraoperatively we have to remove the ramp, we should try to put the patient in head-up position prior to extubating the patient. So Dr. Shaloo, I hope that answers your question.
Yes, post-operatively, briefly, what are the things you take care of?
Yeah, so post-operatively, in the initial period, while the patient is still sedated, we should be using high flow of oxygen. But as the patient is coming out, we should taper off the oxygen and try to reach the pre-operative SpO2 levels. And our aim should not be to hyperoxygenate. And we, wherever possible, try to monitor the CO2 levels as well, because it is the CO2 levels that will help us in guiding how much oxygen we should use. And so aim should not be to achieve 100% O2. If my patient had a pre-op SpO2 of, let us say, 92, 94, then a couple of hours down the line in the post-op period, I should aim to achieve that much and try to use NIV to optimize the end-tidal CO2. So if a patient preoperatively was on a non-invasive support, then in the post-operative period, as early as possible, we should be using. So we need to educate the nurses as well. So if any one of us is following closed claim airway analysis, so a lot of reports have been there where nurses did not call the doctor and they found that, a patient is desaturating, they increased the oxygen, they saw that the SpO2 has reached 97, 98, and they happily left and they thought they have managed it well. Only after a few hours, the patient's attendant came and told that the patient is not responsive. So what must have happened? What must have happened is that CO2 was not analyzed and we took away the hypoxic drive of the patient and the patient became apneic. So a very close watch. So basically we need to train the trainees and the nurses also who are taking care.
Will you keep a high EtCO2 level or a normal level?
No, we will keep a normal level.
Depends on the pre-op period or?
Exactly, it depends on the pre-op period, and we should. So it is important.
Pre-op value or
a little higher is okay. A little higher is okay, but mostly less than 50. Mostly less than 50 should be fine. So anything more than 35 and less than 50 is a wide range, but with some sedation that might be lingering on, sometimes patients do tend to retain CO2. So if I use an NIV and I monitor the end-tidal CO2, I think my patient should be in the safest zone.
Okay, madam, we are running short of time. Thank you for the excellent lecture.
Yes, so I think I will answer that thromboembolism question in the chat box for the person who has asked. Sorry, I could not take up your question. Will that be fine?
Yes, sure.
Yeah, all right. Thank you so much, Dr. Shaloo, Dr. Sanish, and all of you, Dr. Ansar, and all the delegates. Yeah.
Thank you.
Thank you.